So today we'll start off with imaging of spleen. So few theory points that you would want to write in the theory paper. So spleen is the largest lymphatic organ of the body, helps in, phagocytosis of different organisms. Your name also is opsonized phagocytosis. So you are perfect candidate for becoming spleen. Yes, spleen does opsonization and phagocytosis, and there is RBC turnover. So spleen, is the reservoir of all of the blood cells. So it helps in RBC turnover. It helps in maintaining the blood volume. Fine, because it sequesters all of these blood cells. There are two compartments, red pulp, white pulp, and that is what is responsible for the striated appearance that we see on imaging. In the arterial phase, zebra sign, the spleen looks very, very heterogeneous, something like this. And that is because of the anatomy where it's made up of red pulp and white pulp. So the white pulp contains the lymphocytes, whereas the red pulp has a lot of venous sinuses. So it is because of that we see the zebra variegated appearance of the spleen, and there is marginal zone in between. So this is the classification that you got to keep in mind whenever you are writing an answer on spleen or approaching any splenic lesions. We grossly divide them into vascular pathologies, which could, a subtype of that could include trauma to the spleen, infectious and inflammatory pathologies, and then tumors. Before that, you would have a lot of congenital anomalies as well, right? So that's one more heading that you can add to it. So congenital and acquired, and these will be within the acquired. Okay, so this image we will get to. This is describing the typical features of some lesions of the spleen. So this we will reach towards the end after we discuss each one of them, right? So talking about the normal anatomy of spleen, it is semilunar in shape. The average length is 11 centimeter. Whenever you are mentioning the volume of the spleen, like all organs, how do we measure the volume here? So you will find the length and the width of the spleen, and then in the transverse axis, you will take the thickness, right? So these are the three dimensions that we take, and then you multiply it with 0.5. Okay, so the three dimensions, the length can be in, the average of maximum length and the craniocaudal length in a sagittal plane, like here. So this is the formula of the volume of spleen. Normally, we don't really calculate. We give one measurement, and that is this, right? This is the length. So this is the craniocaudal length that you have to give in almost every case if you are not giving the splenic volume. Splenic volume you will only give if it is definitely enlarged, right? So otherwise we don't mention any other dimension. We just mention the craniocaudal length, okay, in the longitudinal plane. Everybody understood? So this is the transverse plane and this is the longitudinal plane. So you take the craniocaudal maximum dimension that should not exceed 11 centimeter, right? So splenomegaly is when this length exceeds 13 centimeter. So 11 is the average, but splenomegaly definition is this craniocaudal length on any imaging exceeding 13 centimeter, right? There are other criteria as well. So let's discuss that. When do we call spleen enlarged? If it extends below the lower pole of left kidney. So here you can see how it's going below the lower pole, or medial extension up to the aorta. So on an axial plane, if you see, not an axial, on coronal only, if you see that medially it is extending up to the aorta. So that's also another thing that's usually we don't see. So two things: if you can't measure the length, see the kidney. If you can measure the length, 13 centimeter, right? About the normal echo texture on ultrasound, it is homogeneous and you compare it with the liver. So this is important that it is higher as compared to liver. So first you need to know liver is normal. So compare liver to the kidney and then compare spleen to the liver, right? So that's something which is important. Does isolated splenomegaly have anything? Yes, it does, right? So we will see the causes of splenomegaly. What could be the causes, right? So isolated splenomegaly does happen. So we'll see that. So ultrasound, the echo texture is, it is hyperechoic to the liver. NCCT, it is homogeneous with an attenuation of 40 to 60 on the non-contrast. On CCT, we will see this typical, serpiginous, zebra-like enhancement on both CT and MR. And that is because of the red pulp and white pulp, okay? Isn't craniocaudal length and maximum length the same? It is. Yeah, it is the same because craniocaudal length is the one that is going to be maximum. Okay. So in this case, what they are probably mentioning, Yeah, I don't know what they're trying to say here. In case there is another length on this transverse section which is higher, maybe that's the one that they are trying to say, that you take an average of both of these, right? So they are trying to take the average of the craniocaudal and the transverse dimension, probably. So you take the length from here to here, and then you take on the longitudinal. Yeah, so technically should be the same, but they mean two average lengths. Okay, the average of two lengths. So this is arterial phase. It's because of the variable sinusoidal blood flow. That's important. In the portal phase, it becomes homogeneous. What about MR? On MR, T1 pe it is hypo compared to liver. On T2 it is hyper compared to the liver. So let's just look at all of the images. So this is a venous phase. You can see how it has become homogeneous, right? Then on T2 you can see it is much more hyper intense as compared to liver, right? So that's what we are seeing. Then look at this image here. Again, T2 you can see it is hyper intense and it is not reaching the lower pole. And then what do you see on the arterial phase? There is this heterogeneous enhancement. And here on the venous phase, again, it's become homogeneous, right? So that's what we are seeing here. So this is about the normal anatomy. Now let's talk about some congenital variants. Okay, so let's talk about variation in size and location. First of all, in size, splenomegaly. So we discussed what is splenomegaly here, and sometimes you may see these lobulations as well. So what are the various causes? One of you is asking, right? Last slide, T2. What about T2? So, causes of splenomegaly, you will have hematologic causes like hemolytic anemia, thalassemia. So, this is where you will see isolated splenomegaly. You will not see hepatosplenomegaly, right? So, that's something which is important. Then rheumatologic like RA, SLE, sarcoid can have, that's usually hepatospleno. Infections, usually liver and spleen both get involved. Congestive splenomegaly can happen. Infiltrative disorders usually will be hepatosplenomegaly, right? So that's something which is important. Fine. Okay. So this, what is the doubt I'm not getting? So you are seeing it is T2 hyper intense with these areas, which are nothing but the vessels inside, right? So now we talk about this. Look at all of these cases and tell me what's the diagnosis. What, this is something you very commonly see around the spleen, right? So what is this? Correct, this is a splenunculus, or we can say accessory spleen, right? So these are splenenculi or splenunculus, which is a supernumerary spleen numerary, okay, supernumerary spleen, or a accessory spleen, right? So this is what we see. Very common. Incidence is 16%, right? So this is pretty high. Fine. Then what are the common locations? So there is splenic hilum is the commonest location. That's where you are seeing it. It can be seen near the tail of pancreas around the gastrosplenic ligament. So particularly in this region, right? So that's where it's commonly found. Here you can see it's lateral. Here you can also see it is, near the pancreas. Now see this case. Is this a splenunculus? You can see that it is matching the density of the spleen, but then something gives away. Do you see one black focus where the arrow is pointing? What is that? That's air. So what does that tell you? That this is actually not a splenunculus. What is it? So what is 1DD of splenunculus? So we are very, fast in saying everything around spleen, which matches spleen is a splenunculus, but you have to be careful. What will this be? Nobody's answering. When you have air focus, what could it be? It's near the stomach. So it's a gastric diverticulum, isn't it? So a gastric diverticulum can mimic a splenunculus. And what gives away? Air. Air will not be seen in a spleen, isn't it? So this is what must be a diverticulum arising from the stomach, right? So that is one, very interesting case here that can pass off as a splenunculus. So you have to be careful here. Fine. Then what do you call this? So you see that there is no spleen in the left upper quadrant. Even on ultrasound, you don't pick up splenunculus so commonly on an ultrasound, right? You do it more on CT. So that's why ultrasound पे तो आपको नहीं दिखता usually. But yeah, if you see, you can see air even on ultrasound, right? So So this is not asplenia. There is no spleen here, but what do you see? That this is where the spleen is wandering, correct? So this is what is